Good day and welcome to today's tutorial session on malignant melanoma. The outline for our discussion includes introduction, clinical scenario, relevant anatomy, epidemiology, etiology, types, clinical features, classification, investigations, treatment, conclusion, and references. Malignant melanoma is simply a cancer of melanocytes of the skin. Melanocytes produce the pigment melanin. Besides being found in the skin, they are found in the uveal coat of the eyes, ears, GI tract, leptomeninges, and oral and genital mucosa. Mnemonic to remember is slug me, where S stands for skin, L for leptomeninges, U for uveal tract, G for GI tract, M for mucosa, that's oral and genital mucosa, while E for ears and eyes. Again, mnemonic is slug me, where S is for skin, L for leptomeninges, U for uveal, G for GI tract, M for mucosa, and E for ears and eyes. Now, these are the parts of the body where melanocytes are found. Let's take note of this clinical scenario. A 50-year-old African black lady presents to your clinic with a single birthmark that has a mole on the distal aspect of her left foot. About 6 months prior to presentation, the birthmark suddenly became itchy and she noticed an increase in size. Following vigorous itching a month later, she sustained bruises and the mole bled. The wound subsequently didn't heal and discharged repellent material which was foul smelling. An examination, significantly enlarged left inguinal lymph node was found. Now, what's your diagnosis? Now, important points in this history were highlighted. First, the birthmark that suddenly became itchy and increased in size. The following vigorous itching, she sustained bruises and then the mole bled. Subsequently, the wound didn't heal and discharged repellent material, and there was an enlarged left inguinal lymph node. So let's just keep your diagnosis in mind and we'll see if you're right or wrong by the end of this tutorial session. The skin consists of two layers, the epidermis derived from ectoderm and the dermis derived from the mesoderm. The epidermis is a stratified squamous epithelium composed of 5 layers: the stratum corneum, which contains keratinized cells; stratum lucidum, which is a clear layer present only in the palms of the hands and soles of the feet; the stratum granulosum, which contains granular cells; the stratum spinosum, which contains prickle cells; the stratum germinativum, which contains basal cells. The mnemonic to remember the layers of the epidermis is CLOGS G, where C is for corneum, LU for lucidum, G for granulosum, S for spinosum, and the last G for germinativum. And I hope you find this mnemonic helpful. The dermis is made up of the papillary and then the reticular layers. So these are the parts of the dermis. This is a diagram showing the layers of the skin. The epidermis is shown right here, while this is the dermis and this is the fat layer, that's subcutaneous tissue layer. The part of the epidermis, I'm sure you can remember, CLOGS G: corneum, stratum lucidum, stratum granulosum, stratum spinosum, and then stratum germinativum. Right, for the dermis, you have the papillary, and then this is the papillary layer, and then you have the reticular layer right here. Melanoblasts are derived from the neural ectoderm of the anterior horn cells. They migrate into the basal layer of the epidermis and produce the pigment melanin in response to a number of stimuli. They transfer this melanin produced to nearby keratinocytes through their dendritic processes. Now, this diagram shows the melanocytes found in the stratum basal. Here they are. And then when they produce melanin, they transfer it. These are their dendritic processes through the keratinocytes present here in the stratum spinosum. Malignant melanoma accounts for 4% of skin cancers. It, however, accounts for 70% of skin cancer-related deaths worldwide. There's a rise in the incidence, having doubled over the past 10 years. Incidence is higher in Caucasians living around the equator because of exposure to ultraviolet radiation. Then there is equal sex predilection. So important points in this slide are account for 4% of skin cancers. That's quite a low percent, but however it accounts for the largest percent of skin cancer related deaths, making it a highly deadly skin cancer. And then it's higher in Caucasians compared to Negroes, and not just in Caucasians, those living around the equator because of exposure to ultraviolet radiation. And then there's equal sex predilection. Pre-existing moles. About 40% of malignant melanoma arises from pre-existing moles, commonly referred to as birthmarks. However, malignant melanoma could also arise from completely normal skin, but it's important to note that 40% of them arise from pre-existing moles. Also, ultraviolet radiation is an important etiologic factor. So having a mole that undergoes a dysplastic or malignant transformation is an important etiologic factor in malignant melanoma. Types of malignant melanoma. N being for nodular melanoma, the most malignant type. A for acral lentiginous, which is common in blacks. S for superficial spreading type, which is the commonest. A for amelanotic. L for lentigo melanoma, which is the least common. And the mnemonic to remember this is nasal. N nodular, A acral lentiginous, S superficial spreading, A melanotic, L for lentigo melanoma. It's important for us to remember the types of malignant melanoma. Again, nodular melanoma, which is the most malignant. Acral lentiginous, which is common in blacks. Superficial spreading type is the commonest. Amelanotic, which lacks the melanin pigment, while L is for lentigo melanoma. Clinical features. Most cases occur in patients aged 20 to 30 years, mainly found in lower limbs in women and on the trunk in men. Common in Caucasians and Negroes, in people with fair complexion, those with red hair, which people describe as escape albinos or albinos. So it's commoner in those set of persons because of the nature of their skin. Symptoms. A sudden change in size is an important symptom to note in taking a history from a patient with malignant melanoma. The patient usually complains of a long-standing mole or a recently developed brown spot, which has grown steadily over a period of a few weeks or months. The mole or part of the mole becomes wider and thicker, often changing from a flat plaque to a nodule. So often changing from a flat lesion to a raised lesion. The color become darker or has a variegated appearance. Variegated appearance means it has different colors. As the mole begins to have different colors, some parts may be dark, some parts may be brown. Then itching sensation is also an early and significant symptom patient may present with. Bleeding. Now, bleeding occurs as the tumor cells multiply. The overlying epithelium becomes anoxic and either ulcerates spontaneously or breaks down after a very minor injury, usually following vigorous itching. Bleeding is slight and a late sign. They are usually not painful, so it's important to remember that malignant melanoma are usually not painful, except maybe they become if they ulcerate and then become infected. Then satellite lesions. Following intradermal lymphatic deposits, a patient may complain of other lesions apart from the mole present. Lymph node enlargement may be present following intradermal lymphatic deposits. Symptoms of distal metastasis also, such as dyspnea, may be present. And a patient would usually present to the hospital because of cosmesis, that's because of the disfigurement that the mole gives. The patient would present to the hospital, and usually not because of pain. Typically, the symptoms a patient with pre-existing mole presents with are summarized into the ABCD of malignant change of a mole. This is a diagram showing the ABCD of melanoma detection, where A stands for asymmetry. That's one half of the mole is unlike the other half. There's an asymmetrical appearance. There's an unequal appearance of the mole. B stands for border, an irregular border which is poorly defined. C is for color. That's the color is varied from one area to another, that has a variegated appearance. D is for diameter, an increase in diameter of the mole, while E is for evolution, as a change in size, shape, or color of the mole. We'll talk about different types of malignant melanoma in details now. Superficial spreading melanoma is the commonest, accounting for 55% of cases. Usually arises from a pre-existing mole, arises on the trunk in men and on the legs in women. It's palpable but thin with an irregular edge and variegated color. So here is a diagram showing a superficial spreading melanoma. The edges are irregular, as you can see in this diagram, and it is thin. It's not raised from the skin, unlike other types. It's not raised from the skin, and it has a variegated look. Some parts are dark, and then these other parts is brownish in color. Lolar melanoma is another type, accounting for 15 to 30% of cases, most commonly seen on the legs and trunk. It is thick and protrudes out of the skin. It, however, has a regular outline and often ulcerates. Lolar melanoma often ulcerates. This is a diagram showing a nodular melanoma. The outline is a bit regular, and then it is raised from the skin, unlike superficial spread that is flat. So this is raised from the skin. Lentigo-marginal melanoma. This is another type of melanoma, accounting for 10% of all melanomas seen in the older age group. It's slow growing and usually reaches a size of about 5 centimeters and usually found on sun exposed areas. Outline is irregular, usually brown or variegated. This type is usually found on apparently normal skin. And the acral lentiginous melanoma is a rare type of melanoma occurring in nail beds, palm, soles, and mucous membrane. Acral means peripheral part of the body, that's the hands and the legs. So you can use that to remember. So when it occurs on nail bed, it's important to differentiate it from subungual melanoma and chronic paronychia, because they are important differential diagnoses. Here's a diagram showing an acral lentiginous melanoma. Classification. There are various forms of classification of malignant melanoma. You have the Clark's classification, which is based on the histologic level of skin invasion by the carcinoma. Level 1 is superficial to the basement membrane. Level 2 is involvement of the papillary dermis. Level 3 is papillary / reticular dermis junction. Level 4 reticular dermis involvement. Level 5 is involvement of subcutaneous tissue. So this is a diagram showing the various levels. Level 1 here is involvement of the basement membrane of the epidermis here. And level 2 is involvement of the papillary dermis. Level 3 is involvement of the papillary reticular dermis junction. And level 4 is involvement of the reticular dermis. Level 5 here is involvement of the subcutaneous tissue. So another classification is Breslow classification, which is based on the level of thickness or depth from the granular layer of the epidermis to the greatest depth of the tumor. Remember the granular layer of the epidermis? Okay, so from that layer to the greatest depth of the tumor, when it's measured, you could tell the degree of thickness or depth of the tumor. So when it is 0.75 millimeters or less, it is 1. Then 2A is 0.76 to 1.5 millimeters. 2B is 1.51 to 4 millimeters. Then 3 is disease that has spread further than the regional lymph nodes. So 0.75 millimeters or less is 1. 2A is 0.75 to 1.5 millimeters. So when you measure, you get this. 2B is 1.51 to 4 millimeters. Then 3 is when the disease has spread than the regional lymph nodes. Here we have the clinical staging. In stage 1, only skin lesions are present. For stage 2A, satellite or in-transit metastases are present. Stage 2B, regional lymph nodes are enlarged. By stage 3, disease has spread further than the regional lymph nodes. So stage 1, only skin lesions present. Stage 2, satellite or in-transit metastases are present. Stage 2B, the regional lymph nodes are enlarged. By stage 3, disease has spread further than the regional lymph nodes. Investigations. A sentinel lymph node biopsy may be done, and this may show the malignant cells. Liver function test is done to rule out metastasis to the liver, so it will be deranged when there is liver metastasis. And chest x-ray is done to rule out involvement of that metastasis to the chest. Abdominopelvic ultrasound scan or CT scan of the abdomen is also done to rule out metastasis to the liver, abdominal lymph node enlargement or peritoneal seedlings. A CT scan of the brain is also done to rule out metastasis to the brain. Treatment. Options for treatment include surgery, radiotherapy, chemotherapy, and immunotherapy. Surgical excision is the mainstay. Surgery is done for primary malignant melanoma. Amputation is done for advanced cases of the soul. The regional lymph node dissection is done when there is regional lymph node affectation. So when the regional lymph nodes are affected and clinically palpable, regional lymph node dissection is done. Radiotherapy is done for tumors of the head and neck because you cannot easily excise them using surgery, so you just use radiotherapy. While immunotherapy may be used as an adjunct to surgery. Interferon alpha 2b may be used alone or in combination with melphalan, tumor necrosis factor alpha, and interferon gamma. Then you have intralesional BCG. In conclusion, cardinal symptoms of malignant change in a mole makes it easy to recognize a malignant melanoma. A thorough physical examination may identify satellite lesions, enlarged regional lymph nodes, and other signs of metastasis. It's important to note that malignant melanoma spreads early through intradermal lymphatics and may give rise to the satellite lesions that a patient might have or enlarged lymph nodes. References: Modification of Lecture Note Liver by Dr. Ernest Udefiagbon, Brown's Introduction to the Symptoms and Signs of Surgical Disease. So, important points to remember includes nodular melanoma, types of melanoma, including nodular melanoma, acral lentiginous melanoma, superficial spreading type, amelanotic, and lentigo melanoma. Mnemonic again is nasal. While N stands for nodular melanoma, A for acral lentiginous, S for superficial spreading, A for amelanotic, L for lentigo melanoma. Typically, the symptoms a patient with pre-existing mole presents with are summarized into the ABCD of malignant change of a mole. This is a diagram showing the ABCD of melanoma detection, where A stands for asymmetry. That's one half of the mole is unlike the other half. There's an asymmetrical appearance. There's an unequal appearance of the mole. B stands for border, an irregular border which is poorly defined. C is for color. That's the color is varied from one area to another, that has a variegated appearance. D is for diameter, an increase in diameter of the mole. While E is for evolution, as a change in size, shape, or color of the mole. Thank you so much, and I hope you enjoyed the video. Can I ask what diagnosis you have in mind? I'm sure you would say malignant melanoma, and if you do, you are right. So that lady had a malignant melanoma, although we can't say the specific type she had, but the diagnosis is malignant melanoma. Thank you and enjoy your day.